Neurology Unit Part 4, Problems of the Peripheral Nervous System. Guillain-Barré syndrome is an autoimmune condition where the immune system attacks the nerves. It is rare. There are less than 20,000 cases in the United States per year. It's unknown the exact origin, but it is triggered by acute bacterial or viral infections. Progression lasts an average of 10 days, and it can take 2 weeks to 2 years to fully recover. Signs and symptoms include ascending paralysis, an autonomic dysfunction or loss of reflexes. Patients complain of feeling pins and needles. There can be weakness in the legs that spreads upwards, unsteady gait, difficulty speaking, chewing, or swallowing, severe cramp-like pains that may be worse at night, bladder and bowel control difficulties, rapid heart rate or cardiac dysrhythmias, lower or higher blood pressure, and difficulty breathing. This slide outlines some information about Guillain-Barré syndrome. Although there is weak evidence to support association with immunizations, according to the CDC. Also, Guillain-Barré syndrome is temporary. There is no single lab finding to diagnose Guillain-Barré syndrome. Cerebrospinal fluid will show an increase in protein, but not for 1 to 2 weeks after the illness presents itself. Management surrounds the poor gas exchange that takes place, so respiratory care is important to assess. Patients may need mechanical ventilation, and healing will occur in reverse order that symptoms came on. The medical treatment is shown on our next slide: plasma exchange and immunoglobulin therapy. Plasmapheresis is the treatment for Guillain-Barré syndrome. It removes circulating antibodies assumed to cause the disease. Plasma is selectively separated from whole blood. Blood cells are returned to the patient without the plasma. The plasma usually replaces itself, or a patient is transfused with albumin. Fresh frozen plasma transfusion is not done due to the increased risk of infection and allergic pulmonary edema. Myasthenia gravis is a deficiency of acetylcholine. The pathophysiology is that it is an autoimmune disease in which the body produces autoantibodies that attack specific receptors located on the surface of muscle cells. In a normal person, a nerve cell stimulated by a nerve impulse releases the neurotransmitter or acetylcholine, which crosses the neuromuscular junction and binds to receptors on the muscle cell, thus triggering a muscle contraction. With myasthenia gravis, the autoantibodies bind to the receptors, preventing acetylcholine from binding to them and thus preventing the muscle from responding to the nerve signal. It is typically slow in progression. If it's rapid, it's often caused by infection, pregnancy, or anesthesia. Worse symptoms occur with repeated muscle use. Thereby, the patient will complain of being tired even with the slightest increase in activity. There is no cure for myasthenia gravis, but it's treatable with medications or surgery depending on the cause. Risk factors include men over the age of 60, women over the age of 40, a family history of autoimmune disease, or a history of thymus gland tumor. Physical assessment will include ptosis, which is drooping of the eye or eyelid, diplopia, which is double vision, dysphagia, respiratory issues, choking, or voice weakness. Diagnosis of myasthenia gravis is often missed or can be delayed because it is uncommon. Diagnosis can be made by blood tests for antibodies, genetic testing, EMG, nerve conduction studies, and medication responses. Myasthenia gravis is one of the most treatable neurological disorders. Classic MG presents with muscle weakness that increases when the patient is fatigued and then limits their mobility. Management is done with drug therapy. Cholinesterase inhibitors enhance the communication between nerves and muscles. They are the first line of defense. They are also called anticholinesterase or antimyasthenics. Cholinergic drugs are another drug of choice. Also, corticosteroids can be used or immunosuppressants. And IV immunoglobulin provides the body with normal antibodies from a healthy person. All of these can be used to treat myasthenia gravis. Nursing interventions include monitoring respiratory status. Adequate gas exchange due to diaphragm and intercostal muscle involvement can be an issue. You may want to collaborate with respiratory therapy. There's also a high aspiration risk due to aphasia and a high risk for respiratory infection. Interventions also include promoting mobility and assessing skin for breakdown, encourage repositioning, and collaborating with physical therapy and occupational therapy. The eyes may need artificial tears because of the inability to close the eyes completely, and it could lead to corneal abrasions, decreased vision, and discomfort. An intervention to tape the eyes shut at night and wear a patch over one eye at a time for 2 to 3 hours at a time can help relieve the diplopia, which is the double vision. Administer medications on a timely basis to maintain blood levels and improve muscle strength. Complications can include the myasthenic crisis, which is too little cholinesterase inhibiting drug. It becomes a life-threatening condition that occurs when the muscles that control breathing become too weak in the diaphragm and intercostals. Symptoms of a myasthenic crisis are difficulty breathing and speaking, retractions, waking frequently at night, increased daytime tiredness, increased MG symptoms. A cholinergic crisis is an excess of cholinesterase inhibiting drug. The symptoms for a cholinergic crisis are abdominal cramping, nausea and vomiting, diarrhea, hypotension, increased tearing or increased saliva, increased perspirations, and it can cause bronchospasm and bradycardia. Health teaching involves teaching about lifestyle changes, avoiding heat, crowds, avoiding overeating, and recognizing a change in sleeping habits or emotional extremes. Teach signs and symptoms of exacerbations, increased weakness, increased diplopia, ptosis, and other problems with chewing and swallowing. Plan activities to allow for rest periods to conserve energy. Educate on signs and symptoms of myasthenic and cholinergic crises. Also, you can share with them about the Myasthenia Gravis Foundation and encourage patients to wear their medical alert bracelet at all times. Restless leg syndrome is characterized by leg paresthesia, which is a pins and needles prickly sensation and burning sensation in the lower extremities, associated with an irresistible urge to move. It is caused by a dysfunction in the brain circuits that use the neurotransmitter dopamine. 10% of the population in the US is affected by restless leg syndrome. Women twice as often as men, and typically middle-aged and older adults experience this. Stress can exacerbate restless leg syndrome. It is also found higher incidences in people with type 2 diabetes, chronic kidney disease, iron deficiency, Parkinson's disease, and peripheral neuropathy patients. Management can be non-pharmacological and drug therapy. Educate your patient on avoiding triggers such as alcohol, caffeine, smoking, and encourage lifestyle changes such as weight loss and exercise. If they are symptomatic, encourage walking, stretching, exercising, or a warm bath. Drug therapy includes dopamine agonists and anti-epileptics such as gabapentin. Other drugs include diazepam and opioids as a last resort. Educate patients on the medications causing drowsiness and that they should take them at night. Also, iron deficiency and magnesium deficiencies affect restless leg syndrome and they may need ongoing supplements. Melatonin can also be used to help with sleep. The trigeminal nerve has 3 branches. The first controls sensation in the eye, upper eyelid, and forehead. The second controls sensation in the lower eyelid, cheek, nostril, upper lip, and upper gum. The third controls sensation in the jaw, lower lip, lower gum, and some of the muscles for chewing. Trigeminal neuralgia is most common in people over the age of 50. It is more common in women than men. It is also familial, an inherited pattern of blood vessel formation. Trigeminal neuralgia causes facial pain resulting in intense facial spasms. It is typically unilateral, one-sided, and typically involving the second and third branches. Causes include blood vessels pressing on the root of the trigeminal nerve, causing the nerve to transmit pain signals. It may also be caused by a tumor or MS if the patient is younger than 30 and the pain is in more than one branch. Contributing factors include trauma and infection of the teeth, jaw, or ear. It also can be provoked by minimal stimulation, such as dental procedures. Pain is described as excruciating, sharp, shooting, piercing, burning, and jabbing, or it can be described migraine-like headaches. There is increased pain when smiling, eating, or performing hygiene to the face due to the pain. It can be mistaken as depression or withdrawal. Management of trigeminal neuralgia involves pain management. Anti-epileptics such as Tegretol or gabapentin or Lyrica can be used. Surgical management involves microvascular decompression, in which they relocate the artery that compresses the nerve. This requires a craniotomy. They can also do radiofrequency thermocoagulation, in which heating a current to destroy some of the fibers, or percutaneous balloon microcompression to decrease the compression on the nerve. In the post-op period, pain management is important, watching for bleeding due to craniotomy, watching for cranial nerve dysfunction, and monitoring for headache. Remember to report any abnormal findings. Facial paralysis or Bell's palsy is an inflammation of the 7th cranial nerve. It is also called cranial polyneuritis. It occurs in all ages, but higher in diabetics and common in young adults. Paralysis can last over 2 to 5 days. There is pain behind the ear or on the face before the paralysis occurs. Patients cannot close their eyes, wrinkle their forehead, smile, whistle, or grimace. Tearing may stop or be excessive. They'll have a mask-like sagging face. Causes include inflammation from formerly dormant herpes simplex 1 virus. Reactivation may be triggered by infection, altered immunity, or exposure to cold. Management of Bell's palsy includes corticosteroids, antiviral drugs, acyclovir, famciclovir, valacyclovir, along with mild analgesics. Educate the patient on protecting the eye, closing it periodically throughout the day, and using eye drops. Ointment at night can be placed in the eye. Wearing a patch over the eye or taping it closed at bedtime. Provide psychosocial support. Educate on chewing on one side of the mouth as it's hard to eat and drink. Use massage and warm, moist compresses on the face and practice facial exercises. Recovery can last weeks to months, and patients may have permanent deficits. They may have permanent neurological deficits, and gabapentin can be prescribed if they have chronic pain. Peripheral nerves are the link between your brain and spinal cord and the rest of your body. They are fragile and damage easily. Nerve injuries affect your brain's ability to communicate with your muscles and organs. Damage to the peripheral nerves is called peripheral neuropathy and can result in motor or sensory function problems or both. Common causes are vehicular or sports injuries, diabetes, Guillain-Barré syndrome, carpal tunnel syndrome, where there's pressure on the median nerve and causes damage. Damage can be either the nerve fibers or the insulation. These are more likely to heal. Severe damage damages both the nerve fibers and the insulation, and the nerve may be completely severed. Signs and symptoms would be a warm phase where there's inflammation, warmth, and redness, and then a cold phase in which the skin becomes mottled and blue. Treatment for nerve damage is surgical repair. Nerve repair involves removing damaged section and reconnecting the healthy ends. A nerve graft is an implant of a nerve from another part of the body. A nerve transfer is borrowing a working nerve to make an injured nerve work. Patients may also need a tendon transfer, and they will need braces or splints for healing, PT, OT, and exercises to promote healing post-surgery.